This is the Mechanical Care Forum, episode 395. It's season 13, and we're highlighting the McKenzie Institute International Diploma Program. We're joined today by three of the educators within the initial theoretical portion of the program, Yvonne Bodie, Mark Cheel, and Grant Watson. We'll talk about their role, the intent with this component of the program, and more. This week on MCF. Hey everyone, welcome back. Thanks for joining us today as we continue to explore the McKenzie Institute International's Diploma Program this season, season 13 of the podcast. This episode is brought to you by the McKenzie Institute International. If you don't know, the McKenzie method of mechanical diagnosis and therapy is globally recognized as a leading treatment for back, neck, and extremity disorders. And as I've said it many times before, personally, MDT has made the single greatest positive influence on my practice, hands down. The McKenzie Institute International offers this diploma program to those professionals who have achieved prior certification in the method. It is the pinnacle of MDT training. Successfully completing the diploma program will place you amongst the world's elite in mechanical diagnosis and therapy. If you're interested in learning more, there are at least two ways you can. First, stay tuned today and be sure to follow us all along through this season, season 13, as we highlight this year's cohort of students through the program and get perspectives from this year's group of candidates, from some of the instructors, which we're highlighting today, from some of the clinical tutors on the clinical residencies, and more. And secondly, be sure to go to the website to learn more about the program and how to apply. You'll find that by clicking on the Education tab and scrolling down to International Diploma. Just go to mckenzieinstitute.org. Okay, so let's get to it. In episode 395, you'll hear Yvonne, Mark, and Waddy share some of the evolution of the program from early years to how it's formatted currently. You'll also hear a little on what each of my guests teach within this 12-week theoretical portion and the intent behind the modules. We'll share a bit of the content taught and even a clinical nugget or two for you to consider and start applying right away. Do stay with us through to the end, and we'll hear what's coming in future episodes. So here we go, episode 395. Enjoy. So with us today on the Mechanical Care Forum, I'm pleased to welcome three excellent colleagues and guests, a part of the theoretical portion of the diploma program. Waddy, Grant Watson, Yvonne Bodie, and Mark Cheel. Thank you guys for joining, taking time to chat a little bit about this topic today.
Thanks for having
me, Jason.
So you guys are well familiar with many out there. I'm sure that there needs to be little introductions, but just for those that might not be familiar, I will let you go ahead and give just a brief mention of where you are, your role, maybe what, in fact, you're doing with the diploma program, with the McKenzie Institute, as well as maybe just your clinical practice so people can get a bit of an idea. Waddy, why don't you start for us?
Okay. I've actually finished with the diploma program. I've actually been involved virtually since the start, since 2004. I had a couple of years off during the Schoology in that first transition, and then Richard asked me to be involved. But this last module that I taught, week 8, was actually my last official teaching function. And my wife and I are both diversifying, we say, rather than retiring. We've got tons of other things to get on with life, but I have some behind the scenes responsibilities still for the Institute that I'm still really, involved with, and love our McKenzie family and looking forward to maybe meeting up in Ottawa next year. But as far as official functions, that was the last.
Wow. Well, I even feel that much more honored to have been able to be in your last hoorah. So thank you, Waddy, for that. Yvonne, talk to us a bit about your role and some of what you're doing.
Thanks, Jason. I've been with the diploma program since I think it's been 2016, which might be around the same time, Mark, you joined also, when it was in Dundee, and then we moved over to Schoology. So I have the opportunity to be a part of, right in the middle, a 2-week adventure with looking at the extremities. So we've been able to see how things have changed over the past couple of years, really addressing some of the learners' needs. And hopefully it's been nothing but better and better as we progress through.
Excellent. Thanks. And then outside of your teaching some of the courses as well, Yvonne, actually, I get to see you teach here in about a week. It's exciting.
Yes, I'll see you soon. A senior faculty with the U.S. branch and also part of the International Education Council. When I'm not teaching for the Institute, I'm assistant professor at the University of St. Augustine here in San Diego.
Awesome. Thank you for that. And Mark, tell us a little bit about yourself and your role.
Yeah, so my work outside of McKenzie Institute is I work at the University Hospital of Geelong here. Geelong is about an hour from Melbourne in southeast Australia. And my role involved primary contact physiotherapy in the ED and orthopaedic screening clinics. I also a clinical lecturer with the Deakin School of Medicine. And regarding the McKenzie Institute, I'm current teaching faculty with Australia. And as Yvonne alluded to, I've also been a part of the diploma program, the theoretical component, since 2016. And also I am part of the practical component where we have a teaching school here, clinical site in Geelong, that's only open to Australia and New Zealand students at this point in time. So we've been doing that also since 2015. And yeah, so with the teaching involving the theoretical components, we started in 2016 when Yvonne and I were come on board and with the Dundee University, and now we've moved to the Schoology platform. And certainly we're conscious of the current student and their demands and needs, and we're always looking at trying to improve the program in order to provide the best fit for the students and also for their clinical practice beyond the diploma.
Mm-hmm. Yvonne and Mark, talk to us a little bit about that. You're alluding to it having been in Dundee before and now on Schoology. Can you talk about some of the changes that came along with that? Waddy, we're going to get your perspective in a moment because you've got just a year or two more, right, of experience with the program way back. But just from the more recent years, what does that mean to those out there listening that don't really have much of a comparison? They don't know what it was like before or what it's like now.
Thanks, Jason. So I would say one of the biggest things was the platform that we were on. We were through the University of Dundee. So we had, as far as the diploma program, had some limitations on how we could present material or even just assessments throughout the progression, which was a little bit of a problem because we didn't have the ability to have any kind of low stakes assessments as we went through and to really see where the participants were landing. And then we had basically a high stakes assessment with their project at the end. So by moving over to Schoology, there's a different platform similar to, if you're familiar with like a Blackboard or a Canvas, that really lent itself for more innovation as from an instructor standpoint, but also the ability to touch base with the students. Like I said before, just allow for some low stakes assessment, make sure everyone is progressing like they should be. And then I would say some better interactive activities and uploading documents and things like that. It just facilitated the process, I think. What about you, Mark?
Yeah, I think you've nailed it there, Yvonne. The big difference is when we went through the Dundee platform, we had two major assessments at the end. I think the current format where we're drip feeding assessments throughout the 10 weeks certainly is more engaging for the students. I think probably the other factor is the improvements in technology, particularly the use of Zoom, where we can have interactive discussions with the students, like in a classroom that we previously couldn't have. I think that's also been very fulfilling, not only from the students' point of view, but also us as the facilitators, that we can have direct contact with the students. So I think that's also been a big progression.
Mm-hmm, mm-hmm. And if those are out there that don't have much context, don't have much history understanding the diploma program, it's basically a 12-week theoretical component. And then at some point, depending on where you're going and how soon you can get in on one of those slots, a 9-week total time of a practicum or a clinical residency. And then, which I thought, well, then it's just a matter of waiting and taking the exam. But I'm realizing, there's a lot of study that has to go on between the practicum and preparation for the examination, which is going to be pretty full in time. But finally, that final examination, which is, I believe, a 2-day process with about 3 or 4 different sessions with the examiners. But if you guys think about the theoretical portion, what is it intended to do? Yvonne and Mark, again, in your perspective, and how has that evolved, just even in the last 6 or so years since you guys have been involved?
Process for the theoretical, like way back in the day, right, when we had the theoretical part of it and then the face-to-face all at the same time. By having it separated at this point, I think it's given the opportunity for the participants to really kind of dive in. And I think part of that, and Jason, you might be able to speak to this too, once you take the credentialing exam, there's a big leap in knowledge between Part D and credentialing exam. And I think you're finding between credentialing exam and diploma, that's even not just a personal growth, but that professional growth and knowledge content that falls. The theoretical is designed to really improve in those knowledge gaps that participants might have where they think they know the content. But as we add more difficult scenarios, differential diagnosis, maybe even some scenarios or cases that you haven't been faced with in the clinic, to have you really push your thinking on MDT and how you can utilize that in all aspects, not just in our traditional, patients that we see in our clinic day to day. What happens if a patient walks in that's a different scenario? So it allows the students to really dive a little bit deeper, reflect on areas that they might not have a strong base, and be able to build that up. So when they get to their clinical experience, it will be even that more engaging and worthwhile.
Mm-hmm. Mark, anything to add to that?
Yeah, I think when we go through the credentialing program, the process can certainly feel like we can complete and it's quite linear. But the reality is that life and clinical practice is not like that. And what the diploma program does do is it really teaches people you've got to actually be thinking outside the square. And that's also with the research. We become a lot more involved with research in terms of the pros and cons. So it really makes you much better at analysis, critical analysis and critical thinking. And what it does do, and this is probably one of my catchphrases I use with students, I think you leave with more questions than answers. And that's a really positive thing, because we can't necessarily accept everything as the correct thing to do right now, because things change and evolve. And so what you do when you go through the diploma program is you go on the front foot and start looking for more of those answers and for what the future holds. And I think that's a real positive step. You really become a much more forward thinker rather than accepting what's been done in the past. And that's the way we're going to be doing things for here and ever.
Waddy, a clinician out there can go through almost an endless number of continuing education courses. They can choose residencies and fellowships and just continuing tracks of some sort or another, manual or non-manual. How have you seen this diploma program evolve over the longer span? And what do you feel like is its unique selling proposition or its uniqueness that sets it apart?
I think, like Yvonne and Mark have been saying, it really gives you an opportunity to study MDT in more detail, but it also gives you an opportunity. We reinforce the fact that we also need to reflect on the strengths and weaknesses of MDT and reflect on other philosophies and what are the strengths and weaknesses there, and to be able to come out from the diploma with a broad knowledge of other philosophies and where MDT fits in contemporary musculoskeletal care. So I think that's something to celebrate. Mark also mentioned about coming out with more questions and answers. And again, that's one of Robin McKenzie's legacies, is that he enabled us, empowered us to say, I don't know. There are things that we do not know. We don't have to have an immediate diagnosis with patients. We can use our clinical reasoning, we can use our provisional classification, but we can also say, I don't understand this, and where do I find that material? Which resources can I go to? Can I go back to one of my colleagues on the diploma program and bounce idea with them? And often they become lifelong friends once you've gone through this melting pot of ideas and all those interactions. So I think that's, some of the strengths. Going back to what these guys were saying about how the program has evolved, that has been extraordinary. Of course, the technology since 2004 has improved so much. But the thing that has been there always, all the way through, is the amount that people have got out of the diploma program. And Pete Wild, who I'm sure we'll come back and talk about in relation to his scholarship, but Pete went through the diploma program and sat the exam in 2009. And I always remember Pete Wild saying to me, you know what, I thought I understood McKenzie when I did the credentialing, and actually then I did the diploma, and it felt like I'd gone into a different profession. I think that just reinforced the level of understanding that he developed from that.
Mm-hmm.
Just one of the other things is the extraordinary amount of communication amongst the group. Now, right back from 2004, when Dunedin started this, took a risk and was one of their first online programs, but they held it up as an example after several years, because what they just could not comprehend was the enthusiasm that our students tackled the program and the amount of interaction across the threads. And that's still so true today. Mark and Yvonne will say this, the amount, and Jason, yourself, the amount of interaction when you come in to be involved on these discussion boards, just the way people from around the world are contributing so comprehensively and dynamically. It's fantastic.
Yeah, certainly makes you realize, okay, I got to step it up here if I'm going to keep up with this group. Yeah. Waddy, tell us a little bit from a historical sense. What was it like back in 2004? Now, again, we know that there's a theoretical component over 12 weeks. It's all online. You get papers, you get cases, or you create cases. In Yvonne's case, this past session there that you create over time. And then you have these discussions. Is that the way it was back in 2004?
Yeah, really from Dunedin, that's how it was set up. So again, I think it's always been 12 weeks, let's say, and then the clinical component. So that was set up from that period. But what has changed so much is the technology. And of course, now being able to have our own in-house Schoology platform is fantastic. And as Mark was saying, especially after COVID, of course, but Zoom now can be such a feature of that.
Mm-hmm. And even previous to 2004, of course, the diploma goes back much longer before then. What was it like in those years?
Oh, you're talking about a long time ago. I did my diploma in 1993, and you and Richard discussed this at that stage. I did mine in Wellington with David Poulter. When it was Wellington based, it was still the big sacrifice and the big commitment that it is now. You guys have talked about it on your podcast and amongst yourselves. I know, I left home to go to Wellington for 12 weeks. This is in New Zealand. We were living in New Zealand. So I went down there for 12 weeks, and it's still family legend how we were all in tears as I drove out. And really it was a total commitment for all that time. I didn't see the family again for the 12 weeks, but lots of tears when we all got back together again, which of course is fantastic as well. So that was what it was like then, actually, in the learning as we go, pretty much. And I was fortunate enough to be involved with the Lodge program. So I did spend some time with Robin at that program, and Greg Lynch in particular was one of my mentors at the Lodge program all those years ago. So then it evolved. You've talked about how it then went to Coon Rapids, but yeah, certainly going online just made it much more comprehensive and basically a university-based program, which gave it merit. Mm-hmm. My only concern initially was people were able to come into these programs without having to do any English exam. And once it became university-based, that became quite a barrier for more of our English as a second language people to actually commit to or get accepted onto the diploma. So I know plenty of people who did huge amounts of learning English even before they started the diploma. So that was potentially a barrier. And one of the advantages of Schoology is that we've been able to not lower the standard, but make it a bit more accessible for people and consider people on an individual basis a bit more than a university-based program could do.
Yeah, I appreciate you mentioning that. I know that we've talked on the previous episodes already with Tina from Denmark and how much of a overwhelming initial shock that was with her speaking, her native language, and then having to transition and just go into English and read all these papers in English. So I know that's a challenge. So you're right. Those people are to be commended. It's one thing for
Absolutely.
us to, it's just incredible. Let's talk a little bit about each of the topics that you guys have been involved with, and just maybe try to give the listener a flavor just from a few moments of time on the actual module that you're involved with and what exactly the intent is of the module and maybe what that looks like. And I'll share a little bit of light that I remember. Now, hopefully it's not too foggy in my recent memory, but Yvonne, you are tasked with the week where we execute an MDT evaluation and treatment management plan for a patient presenting with extremity symptoms. And we actually created a case, which I thought was interesting. And I can share a little bit about a personal issue that I will in a moment as I went through that process. But the key principles were to relate the patient education and extremity joint symptoms utilizing MDT, of course. Talk just for a moment about your module and again, what specifically are we trying to accomplish in that?
Okay, so correct. I'm in week 5 and 6, taking on the extremities in the evaluation and the management. So going from there, but also taking it one step further, and this has morphed over the years also. Started off when extremities were still newish to people. So having the case be a little bit more directed in a more classical kind of classification as we look at it. And so recently, over the past couple of years, taking it over to the classifications that we really don't dive into very much in that other category, right? Looking at inflammatory arthropathies, structurally compromised, trying to get people a little bit touching base with those a little bit more because the first extremity course came out in 2002. So trying to move those extremities along and really, as we've all been talking about before, trying to identify the clinical reasoning, developing that clinical reasoning and critical thinking on if this patient, given this specific classification, were to present. So that was kind of what I would call the easy part. I gave you the classification and a scenario on the patient, very short description. And then it was, okay, let's identify how they would present in the history and then the physical exam. And then once the group had developed that, then the next week was in the treatment management of that classification, really having people kind of dive into, and many wouldn't necessarily have seen those patients or classified those patients. So trying to take the knowledge that you already have in MDT and now let's apply it to the different scenarios that could potentially be seen as far as our classification system and the extremity. I am a firm believer that in order to learn, it has to be a little uncomfortable. And I would say oftentimes, because participants' different level of extremity exposure, it can be limited as they come onto the diploma program, but we want to make sure that we're just not, like for you, Jason, if you only see post-surgical and only derangement, I want to make sure that you have expanded your horizons, if you will, to being exposed to other things and concepts that you already know about how to approach from an MDT standpoint, that you're able to kind of understand that a bit more in some of those other classifications. So yeah, sometimes it's a little uncomfortable at that point.
Right. Well, I'll just tell you, I have had this issue with a couple of joints myself, and it's not been one of these easy things to sort out and figure out why is this not going away. And through that inflammatory arthropathy, I realized, this sounds awful familiar, where I would expect that symptoms won't go away with repeated movements or positional stuff. And if you keep angering that joint through working out and kind of blow through it, you're just going to deal with symptoms on a persistent basis. So, us differentiating through that case of, okay, what should the history look like for this diagnosis or this classification? And then realize, okay, we're going to probably hear this type of behavior. It's going to have been there a while. You're going to have an increase worse, usually, with those type of things, as opposed to produce not worse or increase not worse. So flipping that around where we had to build it out was a little uncomfortable, but it was good. And I think it did exactly what you were hoping it would. So that was a good week 5 and 6. Mark, you were tasked with communication, discussing and evaluating the literature related to 3 areas of communication: motivational interviewing, language, and teach back. Can you share just a little bit about maybe just an elevator pitch of what the candidates, what we received during that week?
Yeah, so one of the things I want to highlight in the intention of the week on communication is exactly what Yvonne said. It's about challenging people's current ways of communication and taking them outside their comfort zone. pretty much every physical therapist that I've spoken to thinks they're a good communicator. When you break things down and you listen to them, there's areas certainly where a lot of clinicians, and that's me included, can improve. And so what we do is we challenge the way clinicians currently practice, particularly around the style of communication they use. So we look at with motivational interviewing, a lot of clinicians still use a direct style of communication, telling the patient what they do, when in reality, depending on the patient in front of you, a lot of the time we should be using a guided style. So getting the patient involved in the consult in terms of their goals and what they want to achieve. And probably one of the biggest things that students take out of this week is the language that we use and how detrimental some of the language we use can be for our patients and their outcomes. So there's a couple of tasks we have on the Zoom meeting, which provide certainly some light bulb moments for the students about how they've practiced and what they can go away and work on. And certainly that was my experience when I started the diploma program. It really challenged the way I communicated. And certainly out the other end now, I'm much more conscious about how I speak to patients. I'm much more conscious about what they're saying to me. And I'm much more conscious about how I pitch my delivery to the patients. And I'm still working on it. And that's my message to students. We can always keep on working on things, because not only does society change, but language changes as well. And what's flavour of the month changes too. So we need to be continually working with society in terms of deliver the best outcomes for our patients.
Yeah. And I was just sharing this with Kim not long ago here on the clinical portion about one of the big takeaways of the 12 weeks was that communication portion where you paired us up, a couple of students together, and you gave us a recipe for your favorite cookies, but it had some very specific instructions as to what was in it and how to prepare it and how to cook it and in what kind of apparatus. And then we were to share that. So we call that written out. We were to share that with our partner. And then we got back together and you asked those who were meant to receive that instruction to teach it back to you. And it was quite interesting that here we got highly educated people who get a simple instruction that has a few things. It's just something that we're not familiar with. And I think the big take home there was our instructions to our patients seem so obvious that, all right, you're meant to do this many times a day with this intention, looking for this response. And oh, by the way, add this piece in as well. Make sure you do it this way. And, all those times that you sit, use this role in this way. And it was quite revealing to me that, okay, I've been a jerk to a lot of my patients, expecting them to know 7 different instructions. So that was a really good piece of information that I think is good for all of us to be reminded of in terms of what we convey to our patients and what we should expect.
Yeah, I think how you communicate with patients, how do you know if you hit the mark? And how do you know whether you're doing the right thing by them? And that's where, with the diploma and certainly having peers and supervisors, it can be pointed out to you about some of your ways of communicating and that maybe it might not be hitting the mark. And I think that exercise, Jason, it really highlights a couple of things. One is that sometimes we're using language that's very familiar to us. I mean, on that recipe, it was very much basic ingredients, but it's very familiar to me, but it may not be familiar to you. And so we're using common words that a lot of patients are not really familiar with. And the second part is we've got to be really careful about how much information we give our patients, because with so much information around us and then you're going adding and adding and adding, you've got to really question the amount that they're taking in. And clinicians can sometimes be very quick to blame the patient for not doing what you told them to do, but in reality, maybe it's a fault of your own by giving them too much information. And that's where we've got to really be mindful of targeting the most relevant and important pieces so that they go take them away and put them into practice. So it is a bit of a confronting exercise, Jason, but I can assure you now my kids are all good at making those recipes because I've spelled it out to them. And I hope that you are too.
That's right. All right, Waddy, you're involved in the week where we discuss and evaluate the process of differentiating between a spinal and or a local source of pain in patients presented with primary shoulder pain. Talk a bit about where that module came from, maybe, and just some of the key points that we as students took away from it.
Yeah, okay, thanks. I'll start off by saying mine's not so confronting. um, so I mean, every module's different. It's great. As the instructors, we make sure that we are not using the same themes, the same format. So every module, we try and make it interesting, different, and there's lots of different ways to interact. Over the years, I was involved with extremities. I remember we had a video of Mac with a knee pain patient, so we used that for people to follow an assessment sheet and go through that. Then I was involved with differentiation of the spine and the SI joint using that video of a patient assessment. But when Richard invited me back onto the Schoology program, I've been primarily involved with differentiation of the spine and extremities, and we looked at the neck and shoulder. So we took Asha Menon's 2012 paper where she saw a patient who had obvious shoulder signs, MRI signs. She started assessing his shoulder using one of the original extremities assessment sheets, and then swapped to the neck, and then classified him and managed him as a spinal derangement. So we used that paper, which was groundbreaking, as an early example of the importance of spinal differentiation. And then we looked at how that had changed our assessment process over that time and management of those patients. So, for example, as I said, she was using the original extremities assessment sheet, peripheral assessment sheet. And actually, Mark and Peter Schock and myself in 2012, when I was running their clinical component, Mark and Peter and I were the ones who had a brainwave and said, why don't we swap from a peripheral assessment sheet to a upper limb assessment sheet and a lower limb assessment sheet, because we'd just gone to part C and part D and differentiated. So really, Mark and Peter and I developed the sheet, ran it through some patients, and then eventually brought it through the Education Council to faculty. So we looked at how that sheet developed. We looked at the algorithm of spine and extremity, and we were able to contrast and compare again how other groups, other philosophies maybe exclude the spine. And of course, the whole ex post literature developing over that period has helped develop that whole module. But it was primarily shoulder spine differentiation and just reinforcing the importance of screening the spine effectively before moving on to an extremity component.
Yeah, and I believe that's the key for at least me, was realizing, okay, this is a great module on the shoulder and cervical spine, but really the principles are there for any kind of extremity. And when do we defer that spine screen, and when might we originally have thought we could defer that and realize, no, maybe we can't defer that. So, yeah.
Sorry, Jason, perhaps just a comment. Again, thinking of the format and how each of us designed our week. So what I didn't use a Zoom. I had the participants in 4 small groups to start with, and they would work on various aspects, various threads that we'd put through, how do other groups screen the spine? What are the advantages and disadvantages of our spinal extremity algorithm? Those sorts of questions. And then one person from the group would take responsibility for a little position paper. And then the second half of the week, all the group would have access to all those 4 papers. And then there would be a more general discussion around each of those papers. So that was a good way of involving everyone in the process, first in small groups and then wider groups, to open out those discussions. And the format seemed to work really well. I was really happy with the feedback that I'd get, both on the evaluations and personally. So
yeah, and Waddy, I will say that working in those small groups where you get to know the others a little bit more than if you were just always in the large group was very helpful and kind of almost bond building, so that we're still staying in touch with each other in between that theoretical portion. And I hear this from a lot of people who've been in it long ago. Oh yeah, I was in the program with such and such and such and such, and we've stayed connected all these years. So from that perspective, it's just really rich as well. But I tell you, it was very reinforcing to me that I feel even more persuaded with this system in general, partly just because I feel like our spine screening is more thorough, and it may pick up on cases that are extremity complaints, but that do have at least a component that's involved from that associated spinal level than others. So that was a great module as well. So tell us a bit about, you guys have told us what is involved in the theoretical. And in a sense, it's given people an idea of what the theoretical component is. Tell us what it's not. Sometimes people have myths or mistaken beliefs about the program, about this portion of the program. I asked you guys to think about this question before. Yvonne, did you have any thoughts about that?
I think what it's not, maybe some perception that people have is coming on and being lectured to the whole time. Like you're going to be given all the answers to things that you just couldn't figure out because they're all in this different manual that you haven't had yet called the Diploma manual. I think it surprises some people about how interactive we want the communication to be, that we want the groups to be. What he talked about the groups, and we rotate those groups throughout the term so that it's not the same people together all the time. And like you said, Jason, there's a bond that develops. And so when we start looking at splitting up the group, there's almost like this grief that sets in where they're like, I love you guys, and as they're on the discussion board, but they don't realize that the next group that they're going to be in is just as great as the group that you just were in. So then, like you said, Jason, that creates such a strong group of people that you might not have had the opportunity if you had stayed in that small group. But I would say what it's not is that didactic, straightforward, here are all the things you're just going to sit and you're going to listen, or you're going to watch these podcasts, and there will be minimal interaction. We're just going to give you a lot of information because it's designed for growth, right? And in order for that growth to occur, people develop that self-directed learning. So I would say that's, for at least for my perspective, that's the thing that I thought of.
Yes. Waddy, myths or mistaken beliefs that you thought of?
I think it's a mistake to think that it's going to be an easy ride through and I'll just keep working in my clinic full time and I should be able to tack on a bit of the stuff at night or whatever in my free time. And again, the different students have different commitments and responsibilities outside of the diploma. But no, look, it is like any postgraduate program. You sweat blood to do it, but it's always worthwhile. So I think absolutely it is clearly a major commitment, and clearly need to ensure that all your support network is in place around you. I would honestly, again, reinforce, like I know Richard did recently, that trying to work full time and commit yourself to this sort of program with the reading involved and the amount of interaction involved is very, very difficult, particularly so, again, English as a second language if you're trying to read articles in English. But I'll just go back to the caliber of the people who we bring onto this program. As Yvonne said, you're in one little group and then you go, oh, do I have to change? And then you change and you go, man, these guys are extraordinary too. Years ago, when Robin McKenzie was not traveling anymore, and not long before he died, and he said to me once, how is it out there in big McKenzie land worldwide? And I said to him, Mac, it's extraordinary. Things are going really, really well. And I said, part of that is the caliber of the people that we attract onto the diploma program. It's extraordinary. And then those people go on into roles within the institute often, or back into their own clinical practice, but promoting MDT. And I still believe that the caliber of the people who come on board is just fantastic for all of us. And I think as instructors, we all recognize that. And again, we're all standing on the shoulders of giants. We always say we're always trying to do our best for everyone as the people who've come before us.
Mm-hmm. Yeah. Mark, any other myths or mistaken beliefs that you might believe it might exist out there?
No, actually, no. The 2 points that both Yvonne and Waddy raised were my 2 points that I was thinking about. And one is that it isn't an easy road, but I would say for me it was harder than what I expected, but certainly more rewarding than what I expected. And certainly it's given me a great platform in my clinical practice, but also from a teaching point of view as well. And to touch on what Yvonne said, that certainly was going through my mind, that the modern day, not only student but person, has easy access to a lot of things and expecting things to be at the press of a button or to be told all the answers. We've got to be very careful of that, because that's when we can fall into traps. What we want to do with these students is we want to teach them to think. We want them to go and get the resources. We don't want them to be listening to everything that we say, because everything that we say may not necessarily be correct. So it's about that critical analysis. It's about learning off each other. It's about getting different resources, not just being given the answers. And so we are very aware of that as facilitators, that we don't want to make it, here's all the answers. We do want you to go away and think, and we do want you to question what we say and what others say, but make it a healthy, robust discussion and all grow from that. And that's really the point that I want to get across to the students, particularly the modern day student when they come on the diploma program. And I certainly think that they not only make a better clinician at the end of that, but also a better person. They're much more understanding of the individuals that they're dealing with, particularly their patients.
Mm-hmm. All three of you have touched on the commitment. One piece of that commitment is not just the time, but it's the financial piece. We know that is a barrier for some, but it does require quite a bit from the teaching side and from the management and administration side. So it is an inevitable. There is, however, some potential assistance with that. And I think, Wadi, you had mentioned that you might wanted to mention about some potential assistance.
Yeah, well, I was just wanting to mention the Pete Wild Scholarship. I alluded to Pete before, and I think there were 4 students on the course this year who were on the Pete Wild Scholarship. Pete was a Kiwi physiotherapist, New Zealand physiotherapist, who went through our program, did the diploma, and moved to America. He was just a wonderful young guy, shaker and mover within MDT, and was going on to do a PhD in Miami he'd enrolled for. But unfortunately, he succumbed to bowel cancer, aged 33. In 2015. But amongst many of us, we managed to approach the International Research Fund Trust, and we have set up a separate Pete Wild Scholarship, which is for diploma students. And as I said, Pete was so moved by the diploma program. This is a very fitting way of acknowledging him and encouraging others to do the program. And I should mention a number of people who contributed, his classmates in particular, and Robert Lindsay and myself and Pete Wild, the Wild family, all contributed. And you can still contribute to that fund on the International Research Trust Fund.
Mm-hmm. Thank you for mentioning that, so people can be aware of that. Any final words on this theoretical component, on this diploma program, or just anything that you guys feel like maybe hasn't been touched on as much, if there are those out there who are just considering this? Yvonne, would you say anything?
Yeah, we've talked about a number of things, the challenge, the financial, personal challenge, the academic challenge. And when we were talking about people, as Wadi was bringing up, people who still think that they can work and do this, I think it's important to realize that you're selling yourself short. This is an excellent program, educational, personal, professional, that I think you should give yourself the opportunity, if I can say, enjoy the journey of it with its challenges, and give yourself the opportunity to get the most out of it that you can.
Mm-hmm. Mark, anything to
add? Nothing extra, but if you are considering the diploma, which I highly recommend, just in terms of the growth for you, you've got to have everything balanced up in your life, and that includes family, your work, finances. But once you get that right, certainly it is something that's going to be very rewarding, and is certainly going to make your career more rewarding too, in terms of at the other end, in what you can achieve and what you can be involved with, and give you the confidence in your abilities as a clinician. So it's certainly been a fantastic journey for me, not only through the diploma, but also now the teaching and beyond. So it certainly is something that I recommend students when they ask me about it.
Mm-hmm. And Wadi, anything additional?
No, I'm happy to ride off into the distance, looking here when we've got Yvonne and Mark and people like that coming through, again, the caliber of the people involved. I have no concerns that the people coming through the Institute will just continue to develop the whole program and the whole philosophy worldwide. Mark and Yvonne in particular, you can unedit this, Jason, but I love Yvonne to bits. She knows that. Yvonne of the beautiful spirit, and Mark I've had a lot of dealings with, and you guys are both amazing. So keep up the great work.
Yeah, well, it's an honor for me to have slipped in right in time to have had you instruct a bit, Waddy, and thanks for contributing to all those clinicians that you have mentored and helped along the way. Waddy, Yvonne, Mark, thanks for taking time to share your perspective on the theoretical component, and thanks for joining the podcast.
Thanks, Jason.
Yes, Jason. Thanks.
Thank you.
Okay, so there you go with episode 395. My hope is that you get a clear picture of the quality of people and elite level of clinicians that the MDT theoretical educators bring to the program. These are just 3 of them, but really in my experience, each one of them, about 13 in total, I believe, are top-notch. Stay tuned to catch up with my classmates following the completion of the theoretical. Did we pass? How was it? And what's next? All this next episode. Be sure to subscribe to my email updates to be notified of new episodes. Subscribe to the podcast on your favorite podcast player and my other social media channels, as we'll be notifying you when each episode comes out. Again, we want to thank today's sponsor, the McKenzie Institute International, providing worldwide training and support to clinicians in the principles and practices of the McKenzie method for the management of patients with spinal and extremity disorders. The McKenzie Institute Diploma program provides the highest level of MDT training. It enables clinicians to acquire an in-depth understanding of the McKenzie method and become experts in its effective use in guiding their patients to achieve their personal goals. If you have an interest in learning more about the diploma program, check it out at mckenzieinstitute.org. And don't forget, we're continuing to plug away here at the Mechanical Care Forum with new cases within case conversations. That's our patient case discussion resource, and new scientific studies within Inside the Science, our peer-reviewed summary and discussion resource. Recently, regarding cases, we've highlighted dizziness and balance from a mechanical perspective. We've also focused on finding full reduction for those patients who show a marked improvement and then plateau. And we've spotlighted preventing recurrence for those situations when your patients get better, but keep returning with flare-ups. And within our research resource, that's Inside the Science, we've spotlighted papers on the drivers of pain and disability and mastering prognostic tools with Yannick Tousignan-Laflamme. These are intended to provide some virtual mentoring for you and help keep you moving forward in your professional development. You can check these out at mechanicalcareforum.com. All right, I wish you a great week with your patients. Reach out and connect with other clinicians to continue to grow, or take the plunge and go all the way, like applying for the diploma program. The consensus is you won't regret it. And join us right back here next week for more from Season 13 and sharing experience for improved patient care.